I'd like to now turn to Dr. Joseph. And I want to again express my appreciation for your willingness to be here nearly every Friday morning and to help navigate us through the do's and the don'ts of dealing with COVID. So, Dr. Joseph, what do you have for us today?
Well, thank you, as always, Mr. Mayor. I appreciate the invitation and the opportunity to discuss the medicine side of so many topics. I'm going to share the screen, if you can help me do that, Steve. There we are. So this is what we're going to try to address today. A few comments about COVID in our county, some comments about this disease in children, which is really a different disease, and maybe some of the thoughts as to why it's different. And then I've picked a few things to discuss from the medicine side about reopening schools and summer camps. So we'll start with COVID in Contra Costa County, and off to the right is the graph. And the graph really says it all. Supervisor Anderson has mentioned it many times. That steep part of the graph is what everyone is concerned about. That's what we don't want to see. That's the spike. That's where you talk about leveling the curve, flattening the curve, wanting to see the curve go down. This is the number of cases reported by day, or the number of new cases. So I put some things on the left that are maybe related to this. At least I can give you my opinions. That 4 months ago, we had a stay-at-home order, and that lasted for about 2 months. A month after that, there were face coverings recommended. And on May 18th, we began to reopen some retail and commercial places. Now, if you take out that COVID fatigue line, I think there's been too much emphasis saying that the spike or the increase in the number of cases was related to reopening. In actual fact, it probably is not. Reopening was very well structured. And when I go to retail places, I find that is where people are doing exactly what they should be doing. It's rather well policed, or at least it's emphasized. I think our problem now that occurred through May, June, and even now is COVID fatigue. The big three still work: face covering, distancing, wash your hands. Those are the big three: face covering, distancing, and wash your hands. And we are seeing a tremendous amount of people who are saying, I've had enough of this. I want to socialize. I want to go out to dinner with my friends. I want to have people over. My kids need to play. And I understand all of that. I'm not at all critical of it, but rather saying that I think that is what we are seeing as the change in the curve. The virus is relentless. The virus will take an advantage of any time we let down our guard. And that's why Supervisor Anderson and so many others are saying, come on, come back. We've got to go back to the basics. Masks prevent spread. Hand washing prevents disease. Distancing prevents spread. And that has to go back to normal. And yet I think so many people have just had enough of this that they're letting down their guard. So what we need to do is to continue to emphasize that for ourselves, our households, and our friends. So now we'll go on to children. COVID in children is a different disease, but it is very poorly reported, and it is not uniform throughout all 50 states. So there is an estimate that about 185,000 children have been infected in the United States, but children is not defined. So in some states, the COVID disease is reported by age. Others, it's reported by age groups, such as 0 to 1, 6 to 10, 10 to 20, but it is not uniform. So it's very difficult to come up with some good information that, like we do with elderly, like we do with seasoned adults. What we do know is that they have an entirely different disease for the most part. The symptoms they have really look like a cold. They look like a viral disease that any child might get at school, at the playground, or around the house. Fever and a runny nose may be all they get, or a cough and a runny nose, or any of those may be all that is seen. It's definitely a milder disease than one sees in adults. And that translates scientifically to a couple of things that are probably important. Their disease is milder because they don't seem to get the viral replication that adults do. I have no reason for that, but it's factual. They have lower amounts of virus and they shed lower amounts of virus. And so it is assumed that they are less contagious than an adult with a high fever. In fact, the sickest person, the person in the ICU, the person in the hospital, or the sickest adult at home is the most contagious. Those who have the mildest disease are the least contagious. They are shedding smaller amounts of virus. Now, why they have this immune response that is weaker than adults is unknown, but it does translate to not as many antibodies. So children don't produce antibodies as well as adults. And the concern there is not that the amount of antibodies, that's just a laboratory result, but will they have a shortened immunity? So the sickest people produce the most antibodies and they stay the longest. Those who are least sick may have a shortened immunity and they may not be immune for as long as others. This is all work in progress, but it's very suspicious that children may be more susceptible than adults for a second infection. And any discussion of children would not be satisfactory without mentioning the multi-system inflammatory syndrome. This is very similar to Kawasaki's disease. There have been several hundred cases in the United States. This is the main reason we don't want a child to get COVID, because the multi-system inflammatory syndrome is a life-threatening disease and also a life-altering disease. As you can see, 80% of them end up in the ICU, and when they get out of the hospital, long-term consequences are common. So the multi-system inflammatory syndrome is the main reason that we want to protect our children from getting this disease. Now, there's some nice numbers on here, and I show this because it's very difficult to describe this, but this is what we know from modeling, and I put the age groups over on the left. Infants we will call less than 1, then there's the 1 to 5, 6 to 10, and those who are over 10. Let's take it from the top. Generally, an individual who is over the age of 10 years acts just like an adult. There's really very little difference in the disease, the symptoms, the immunity, the complications between 10 and 40, and the mortality rate between 10 and 40 is very low. It's 0.2%. On the other hand, on the top line, infants get a very, very severe disease. Less than 1, it is critical. And you can see that 1 in 10 infants who gets this disease is going to be in the hospital. They get severe or critical disease, and even a relatively reasonably high death rate. Mortality is unknown, again, because we don't have good information. This is all modeling. Now, the middle two lines are probably what we're concerned with in schools, and we want to try to address that mostly today. What we know is that you can see the percentages there. As an individual gets older, the likelihood of critical disease goes down. The death rate is the same for all of them, but it's estimated. But look how low that death rate is. It is a fraction of a percent. And that's why you hear in conversational languages, well, kids do just fine. And in general, they do. They have a very, very low rate of getting a critical illness, a very low mortality, a lower likelihood of spreading disease, and therefore there are these concerns about, the lack of concern for children compared to elderly adults. So this unfortunately is all modeling because we don't really have good numbers yet, but this is probably pretty reliable. Now, Mr. Mayor asked me to discuss a little bit about schools and camps. And this is the way that I look at it. Before a decision is made, it requires input from several disciplines. Educational professionals like Mr. Schmidt and Mr. Mintz and many, many others, certainly parents, elected officials are very importantly involved, like you, Mr. Mayor, and all the way up to the governor. Input from the health department goes without saying, but then school nurses need to be involved because they're going to be on the front lines now. It's not going to be the first responders, it's going to be the school nurses. And obviously the sociology or the socialization of children and the psychology is very important. And this slide gives me an opportunity to say, I play just one little part. I can talk about the medicine, but nothing else above it. I can tell you what we know from the science side of this, and then I defer the others, the input from all of the others to specialists in those fields. And so we'll talk a little bit about the medicine side and what we have learned from my discipline. The common language on the street is, well, we should reopen the schools. They've had no problems in Denmark or Austria. And then the other side of the coin is, no, they had terrible results when it was done in the United States, in Missouri and Texas. And Israel was catastrophic, and they had kids and deaths, and it was spread to the families. And so we try to see what's different about those who had a favorable response to reopening schools and those who had an unfavorable response. And it would appear that the determining factor is in that right column. That is the background rate of activity of COVID in the community. So you can see at the bottom, Denmark and Austria had very few new cases per day per 1 million population. And that means that the background activity in the community of COVID disease was very low. On the other hand, Israel, Missouri, and Texas had a lot of new cases ongoing in the community. Missouri and Texas opened summer camps and had horrific outbreaks. Israel opened schools and had a terrible result, but you can see what's going on in the communities where they elected to do so. So right now, this is probably not the only important information, but it's the only information that we have. And it looks like it is somewhat of a determining factor. So I'm going to show a next slide and input California and Contra Costa County in comparison to these. And they'll be on top in blue. So we look at Israel, Missouri, and Texas, and they're in the 200 to 300. Denmark and Austria are way below 20. And this is where we are in California. The state of California has about 226 new cases per day per 1 million population. And Contra Costa County is somewhere around 130, but with the numbers that, now this is per million, not new cases, but new cases per million. Contra Costa County is pretty close to a population of 1 million. I think it's about 1.3. So when Supervisor Anderson said today that we have 160 new cases, that number of new cases per day for Contra Costa may be even higher than 130. And this creates concern. This is the only numbers that we have to look at. And we can see why everyone we're not flying through this like Denmark and Austria. Now, let's talk about this though in a different way. If we're going to talk about California, you can see the numbers very high. If we talk about Contra Costa County, it's much lower. And then there may be smaller communities where the number is even lower, or as implied by Supervisor Anderson, there's other communities within Contra Costa County that are extremely high in the southwest part. So this may be more of a microcosm or a micro community issue than it is by lumping it. This could be a case where splitting is better than lumping. So to address that in a different way, and I didn't put down all of the medical considerations, but I put down some selected things to discuss. The background risk is the community incidence, and incidence is a scientific term for the number of new cases. So the number of new cases per day. Now, if we're talking about a traditional school where kids may come to school from all over the county, then the county becomes the background risk. If it turns out that we're going to do micro schools or mini schools, which by the way are terms I'd never heard before the COVID epidemic, but if we're going to have groups of kids, of 5 kids or of 10 kids, and it is a bubble, it is a defined area, that may be safe if we know the incidence in that defined area, in that defined family set. So it looks like from the medicine side, not an educational side, not society, not psychology, but from the medicine side, the community incidence or the location or the micro community incidence is going to be a very important consideration. The next thing, and I've said this before, is the consequence. There's the risk, and then there's the consequence of somebody getting infected. And that is very individual. So if we're talking about a family where both parents are under 40 and the kids are healthy and they don't travel out of the house and their family unit is very confined, well, the consequence of an infection in that family would be low. But if in that house, one of the parents is getting cancer chemotherapy, or there's grandparents or someone in the house who's very elderly, or even the student, if the student is immunocompromised or the student has to take immunosuppressive medications, then the consequence of an infection is very important. So the background risk and then the consequence are the 2 big issues. And I've said that before. And that's for anything, by the way. No matter what, the biggest question I get is this safe? And this could be anything. Is it safe to ride on an airplane? Is it safe to ride on BART? And those are the 2 concerns. What is the risk and what is the consequence if you get infected? And then I put down some things that really apply to schools and even mini schools. And these are policies that we do not have, but must be considered if we're going to go this way. Now, I'm giving you the medical opinion, and these policies need to be written in advance. And I'll go over some of these, but what you can see is it's not just throwing a switch. Well, let's open the schools. This is a new ball game. We really need to be prepared for things that we've never had to look at before, even if we're talking about 5 students being in one house. The first, are we going to screen and test students and teachers? Is screening going to be done just by checking the temperature when they come in, or are we going to require a questionnaire? And are we going to test everybody? And if we test everybody, are we going to test everybody regularly? And let me digress for just a moment on testing. I couldn't agree more with the comments about testing. It is totally unsatisfactory to wait 14 days for a test result. The 2 biggest laboratories in the United States are Quest and LabCorp. And yesterday, the LabCorp commented to me that it is absolutely impossible for us to ramp up testing to meet demand. There are not enough people, not enough reagents. We're working 24 hours a day. And the reason is that the demand for testing has exceeded the capacity. But testing is going to be important. And I will say one other thing on testing. One of the exciting things that I did on Monday is a saliva test. It turns out that if you can create about 5 milliliters of saliva, so that'd be a teaspoon, that there's about 10 times the amount of virus because of the volume, then you can collect on a little flocculated swab. So a flocculated swab that we do, this is what has been known as a brain biopsy, or where you put the swab deep in the nose. It can only capture so many epithelial cells and so much mucus. But saliva, because there's almost no limit in the volume, has much more virus in it. And if that test becomes widely available, it can be done very quickly. And that's something that is much more applicable to doing on a regular basis for children, students, teachers, whatever. So that has to be addressed. training of what the children should do, not just the teachers, but infection control training. And I'm always impressed at how well students learn. But they do have to learn practices that they've never had to do before. Keep their hands away from their face. Wash their hands frequently. Pay attention to what they touch. Be very concerned about their other students, their classmates, because they can spread the virus if they have no symptoms. Face covers is we've discussed it many times. I put as applicable because in schools it's going to be a whole different situation, and I will defer that to others. That is, we know we don't put them on children under the age of 2, but whether face covers are even going to be possible at all in children in school on K through 8 is something I would have to defer. I can tell you how they work, I can tell you what they will do, but I can't tell you if they can be done. Distancing and playing. So there's some new information on this. So in children, the answer may be 3 feet instead of 6 feet because they shed less virus. Now, I have a question mark there because this is still being explored very, very carefully, but it may 6 feet for adults, because if I am infected with this virus, even if I have no symptoms, I'm going to be shedding a lot more virus than a student. So it's possible that we have an opportunity to cut down the distancing in schools to 3 feet. Environmental cleaning and disinfecting. This is new. We will need written policies, or I should say, I would suggest written policies, because it's going to be a different kind of cleaning and disinfection than the usual janitorial services. Hand washing and hand sanitizing goes without saying. There's going to be a need for hand sanitizers at all touch points, at all doorways. High touch surfaces such as keyboards, desks, bathrooms will have to be disinfected on a regular basis, or some form of way that they will not become contaminated. And that might be tissue papers at the doorway so you don't touch a doorknob with your hands. Outdoor versus indoor. I mean, if we can do outdoor, it is a gift. Spreading this virus outdoors is so difficult compared to indoors. Outdoor air currents take this virus away. Indoor, there are very few air currents unless they are mechanically created, which is what is being worked on in a lot of places now. But if teaching can be done outdoors versus indoors, the safety factor is huge. Engineering controls it's a way of protecting things. It's a buzzword that is used in medicine and in infection prevention. And what it means is creating doorways, desks, handles, knobs, things that are safer and less likely to spread infection. And I defer those to individuals who are specialists in that. But you know, when you can do this with an engineering control, you don't need to rely on personal habits. And the last one, it's last for a reason. This is going to happen. What are we going to do if a student is positive, or if a teacher is positive, or if a student is exposed? What do you do if you're in class and a student comes to class and says, my dad is in the hospital with COVID? These are very, very tricky situations, and it will happen unless that curve drops off quickly. All of these are real considerations. So there's a lot to it. I am happy to discuss the medicine side, and I've said this many times. I make recommendations, other people make decisions, but I can see that this decision is a very, very tough one to make. And I just have all the respect for all of you and all of the other disciplines that are involved. My role in this is easy, but making the decision is tough. Mr. Mayor, once again, thank you very much. And that's all I was going to discuss for now.
Great, thank you.
All right, we have another question. I believe this is for Dr. Joseph. Can you explain what is pool testing, and is that a method for increasing the number of people being tested in order to shorten the response time?
Yes. Pool testing would be taking a swab from 12 different people and putting all 12 swabs into a liquid medium and running one test. And if that test is negative, then all 12 persons are negative. So you can shorten the turnaround time, shorten the testing time. If that test is positive, then each test has to be done individually to find out why it was positive. To do this, the FDA has approved this, but each test system has to be validated so that it works. And it is a very promising way to facilitate testing more quickly.